Hello, my name is Mike Henry, and I am one of the current glaucoma fellows here at the Illinois Eye and Ear Infirmary. My talk today is titled Novel Medical Therapy From New Drugs to New Delivery System. I have no financial disclosures. Pharmaceuticals are the current cornerstone of glaucoma therapy. Although the LIGHT trial clearly demonstrated the effectiveness of first-line SLT, topical ophthalmic agents remain the most common first-line therapy. Eye drops are extremely effective and play a critical role in preventing glaucoma progression and future incisional surgery. Despite these benefits, patient compliance is lower than eye professionals think. One study using pharmacy claims data showed that patients filled prescriptions for topical prostaglandin analogs and had medication available for dosing only 37% of the days in a year. This non-adherence has consequences. The Collaborative Initial Glaucoma Treatment Study demonstrated a statistically and clinically significant association between medication non-adherence and glaucomatous vision loss. This poor compliance likely stems from cost, inconvenience, and toxic side effects from the medication. The prolonged use of eye drops preserved with benzalkonium chloride is a strong risk factor for ocular surface disease in patients with glaucoma. BAK's toxic, pro-inflammatory, and detergent effects have been shown experimentally and can lead to irritation, dry eye, allergy, subconjunctival fibrosis, or increased risk of glaucoma surgery failure. BAK is found in consumer products such as hand sanitizers, wet wipes, mouthwashes, Lysol, and algicides. Reducing the overall preservative load may improve adherence, quality of life, and the patient-doctor relationship. Allergan's bimatoprost implant, along with Glaukos' iDose and Ocular Therapeutics' travoprost implant, have potential to improve adherence and reduce treatment burden in glaucoma. Bimatoprost SR, or Durysta, is an FDA-approved intracameral implant that releases bimatoprost over time. The device is very easy to use. Here, I will outline the steps. Durysta is removed from the storage refrigerator and opened. We first inspect the applicator. We ensure the 28-gauge needle is not bent, that the actuator button is not pressed, and that the blue safety tab is in place. When we are ready to use the device, we remove the blue safety tab by pulling straight perpendicularly out from the applicator. Then we remove the safety cap. The applicator is held with the thumb on the back half of the actuator button and the middle finger supporting the opposite side of the applicator. The eye is prepped under standard aseptic conditions for intracameral procedures, and the patient is positioned at the slit lamp with or without a lid speculum. The 28-gauge needle enters the anterior chamber, and the actuator button is pressed. The implant then settles to the inferior angle. The implant is made of polymers that slowly release bimatoprost as it biodegrades through the process of hydrolysis into carbon dioxide and water. In vivo studies show that the implant releases a continuous dose of bimatoprost for 90 days. However, Phase 1 and 2 studies showed that a single administration of Durysta lowered intraocular pressure for up to 1 year in 40% of patients and up to 2 years in 28% with no additional treatment. Phase 3 studies followed patients who underwent 3 consecutive injections spaced out by 4 months. The probability of not requiring additional IOP lowering treatment for 1 year after the final implant was 82.1%. The implant stops emitting drug at 90 days, and the drug is not detectable in the eye 120 days after injection. So why and how are the effects of the medication sustained up to 1 or even 2 years? Long-term treatment with topical bimatoprost has been shown to cause changes in morphology in the ciliary body and trabecular meshwork consistent with the formation of new outflow channels and enhanced outflow. The hypothesis is that the targeted delivery and higher concentrations of bimatoprost achieved in outflow tissues with Durysta compared with topical dosing cause greater upregulation of matrix metalloproteinase activity in the target tissues and more durable tissue remodeling, resulting in sustained IOP lowering. This long-term tissue remodeling is probably one of the most exciting and intriguing aspects of the intracameral implant that came out of the Phase 3 Artemis study, and may one day truly be a game changer for our field. However, there was also some troubling data regarding endothelial cell loss that was also uncovered. In the Phase 3 studies, patients were given 3 administrations of Durysta at fixed 16-week intervals. The incidence of 20% corneal endothelial cell density loss was 10.2%. Additionally, 3 out of 396 implant-treated subjects had a greater than 2-line best-corrected visual acuity loss at their last visit. There were no such events in the Phase 1 and 2 trials where the majority of patients received 1 implant, and time in between readministration and those who received 2 implants was much longer. Nevertheless, as a result of these corneal endothelial cell loss data in the Phase 3 trial, reinjection of Durysta is currently off-label, and it is not recommended in those with compromised corneal endothelium. If I were to describe my May 2021 view of Durysta, I would say it is similar to femtosecond laser-assisted cataract surgery. Is it useful for certain cases? Yes. Is it exciting technology? Absolutely. Now, in its current form, should it replace how we do things? No. Should we use it in certain patients? Yes. I do not consider Durysta a long-term solution. However, it can provide patients time for the ocular surface to heal, time for patients to recover from medical issues, time for family members to arrange schedules. In time, this technology will advance and provide sustainable and safe long-term solutions for our patients. Thanks for your time and attention.